So, how was your day today? Did you have a good day?
Okay, so we're gonna go ahead and get started. Thank you everybody for joining us tonight for the January Deaf Health Talk. It's sponsored by the University of Michigan and partners in Deaf Health. Today we have one of the AMPHL Board of Directors, and he is also a deaf psychologist in the state of Washington. I'm going to do a whole presentation about Jamie in a minute. And one of my really good friends. So I'm really excited about this talk tonight. Before I get into the talk, I just want to go through our ground rules. So tonight we will have our talk. We will have speakers do the presentation. At the end of the presentation, we will have question and answer session where the audience can ask all the questions they have or make comments or whatever they want. This event will be captioned, and it also has American Sign Language interpreters. We have two interpreters with us tonight. We have James and we have Lindsay, and then we have Kate as our captioner. So I would like to go ahead and introduce our speaker. So this is Dr. Jamie Wilson. He is a prescribing medical psychologist and board certified neuropsychologist. That was a mouthful right there. Hi, my name is Sarah Hines, and I'm a nurse practitioner in the state of Michigan, and I actually work for the Veterans Affairs, so that's why I was really fancy the logo right here. So I work for the federal government, and I actually take care of our veterans. So if you don't know, a lot of our veterans have hearing losses, so that's really interesting. I would like to go ahead and turn it over to Jamie because he had a lot of great stuff to share with us tonight. He's going to be talking about dementia and cognitive decline. So this is something that you will see in the elderly population. So Jamie's going to take over and I will help add things from a primary care perspective. Okay, so go ahead, Jamie.
All right. Thank you so much, Sarah, for that introduction. I really appreciate that. I'm very excited to be here with all of you this evening. Really, thanks to the technology that allows us to be able to get together in this space all over the country. How fascinating. So, I have an outline that I'm going to refer to from time to time. And I'm going to go through it and explain some of the features of dementia. And if you've got questions about anything that brings up, like Sarah said, save that because at the end, we'll have a question and answer time. One thing that I wanted to explain related to dementia is the sign. We see this sign for dementia. And the reason that we sign dementia this way is because persons with dementia don't just have problems with forgetfulness. It's not just a memory issue. It is also a more complex issue related to behavior, language, so the forgetfulness in their mind, but also forgetfulness in terms of communication. There's a linguistic piece to it. So that's why we sign this for dementia. So we'll have dementia, and then we'll also speak on delirium, which is signed this way. Often we'll see delirium and dementia kind of overlap. So when a person comes in, they're presenting with delirium, but it looks like dementia. So it's something that we have to tease out, where in fact they don't have dementia, and there are differences that we have to be able to identify. So delirium has confusion with depression, and sometimes that depression can manifest itself in a way that looks like dementia. So, how we separate these symptoms and signs to make sure that dementia, delirium, and depression are distinct. So, we'll talk about how we evaluate that in a physical exam and also with a neuropsychological evaluation, which is a type of test. Dementia tends to happen over time, months and years build on each other as a person with dementia continues to decline. Delirium is a sudden onset, so it can happen over hours, maybe days, and it happens quickly. With depression, it can be tough because that person could be talking about experiences that have happened for such a long time, and teasing that out with the doctor can take a lot of work. Depression tends to have no A person with depression tends to have no energy, no motivation. They would rather withdraw from the world around them. Just they feel like they're bystanders. Their personality goes through real dramatic changes, and their willingness to participate just dissipates. So I want to talk a little bit more, if you don't mind, about dementia. Interesting thing about dementia is that there are over 100 different types of dementia. And really, sometimes people, well, they think the older we get, that dementia is a normal process of aging, but it's not, right? So, dementia is not a normal progress of aging. There are some areas of the brain that tend to shrink as we age. And the areas that tend to shrink as we age are four in particular. So there's one area called the tertiary association cortices, which we know as TAC. We refer to as TAC. And that area of the brain is roughly here. And that's the parietal lobe. And that's our sensory. That's where sensory issues develop. So what happens is that area of the brain shrinks. Our taste, our ability to tasting declines, our ability to hear declines, our ability to smell, our eyes and our vision all decline. So that's what happens when that area of the brain shrinks. Another area of the brain that tends to shrink is the hippocampus. And that's going to be right in this area. It's what's called the temporal lobe, right, of the brain. The hippocampus is responsible for memory and learning. And that's where our brain transitions things from our short term memory to our long term memory. So that's an area of the brain that will shrink a little as well. It's very interesting because older people aren't like less intelligent or lesser than younger individuals. older people can, well, when they learn something new, it might take them a little bit longer to process that information, but they're less likely to forget that information once they learn it. So older people still have that benefit over younger individuals. The hippocampus, as I mentioned, is the second of the four that will shrink. The third area is the caudate, and that is in the middle of the brain. It's part of the frontal lobe, right? And that is responsible for automatic learned behaviors. So that's things like, for example, for drivers who are used to shifting, I know when to shift, I know when to downshift. I don't have to look at the RPMs and then shift. I'm used to shifting at a particular time. So an older person might leave one of their gears in a particular slot for too long before remembering to shift. Another example is an older person who might be used to doing the laundry a certain way. And then they'll go to the dryer, but instead of looking in the dryer, they look in the oven. So the caudate, which is part of that automatic learned behavior, will shrink. And the last part of the brain that shrinks is this part of the brain right here, which is the cerebellum. And that's part of the occipital lobe. So that's hand-eye coordination. So older people tend to trip and fall more, right? We see a lot of that older generation breaking hips. And that's because their hand-eye coordination is not as good as it was. So those four areas of the brain will shrink, and that's considered part of normal aging. But a person with dementia might forget where they put their keys, their glasses, or their wallet. And they're normal everyday things, right? If you forget you put them, that's normal. When it becomes a problem is when you don't notice these memory issues. And if you're not in the if you don't realize you have memory issues, that's when it could be a hallmark, a very clear signal that a person's forgetting things. They're forgetting names of their loved ones, their partners, their spouses. They're forgetting things like paying the bills on time. They're not behaving in a way that's typical to how you should behave in a situation, or not setting things up like the way that they did in the past. Or they're starting to not even notice that their behavior is off, and that's when it becomes a problem. So, as I said before, there are over 100 different kinds of dementia, but we have four, I think, which we would say the most common forms of dementia that we see in a clinical setting. The first one, which I think all of us would recognize, is Alzheimer's. And that is ALZ. The sign is like this. A person with Alzheimer's, well, it comes on somewhere between 50 and 70% of cases of all dementia. Right? So 50 to 70% of dementia cases are Alzheimer's. the onset is around 65 years old. A person with early onset Alzheimer's, which is before the age of 65. If it's after the age of 65, it's called late onset Alzheimer's. And you might think it's interesting that there's a distinction between early and late. But the reason that's important is because if we have someone with early onset Alzheimer's, they tend to decline quite quickly. And within 5 years on average, they've lost most of their cognitive, as opposed to someone who has late onset Alzheimer's, they have a very slow progression to the disease over about 10 years. So the risk of getting Alzheimer's goes up as age goes on. So I would say, like, if a person in their 70s, there's about a 5% chance increase of getting Alzheimer's. In their 80s, they're increased 8% chance of getting Alzheimer's. And in their 90s, it's a 56% chance of developing Alzheimer's. A person with Alzheimer's exhibits behaviors, just they don't socialize as much as they used to. They're withdrawn. They're less involved with activities. You might see them become increasingly aggressive. There's a term called sundowning behaviors, which means that person's awake all day, and so they get quite fatigued, and so they're grumpier. They're a little less friendly, and it's harder to control their behavior by the end of the day into the evening. Also, we'll often see something called confabulation. So confabulation is quite a large term. And what it means is that a person can't remember something. So what they do is they make something up instead. And it's something comparable that's believable. For example, if there's a couple, one second. If I have a couple come into my office, could be a husband and wife per se. And I'll ask the husband, "What did you eat for breakfast this morning?" They'll say, "Oh, I had bacon and eggs for breakfast." And then I'll ask the wife, "What did your husband eat for breakfast?" And she would report, "He didn't eat bacon and eggs. He had cereal," which is a good example of confabulation. The person didn't try to lie. The person didn't try to make up something, deceiving. They just tried to get through the situation by coming up with something that fit. And that's based on the truth, right? So that's confabulation. So we see that often in persons with Alzheimer's. So Alzheimer's is the most common type of dementia. The second most common type of dementia is called vascular dementia, which I'll sign VAD, vascular dementia. So that comes on in about 20 to 30% of all dementia cases. That tends to start a little bit earlier, than the average Alzheimer's patient. Vascular dementia shows up in a person between 60 and 75 years old. Really, vascular dementia is related to the circulatory system. So when there are any blockages of blood vessels, it stops RBC, which are red blood cells. So red blood cells carry oxygen to different areas of the brain. And of course, the whole body as well. But when RBCs are blocked from reaching certain areas of the brain, we start to get something called an infarct. And that's when a blood vessel dies. So these blood vessels in areas of the brain, right, areas of the brain shrivel. And that affects our memory. And then our cognitive functions begin to decline. It also affects other behaviors, but it depends on where the blockages are, which vessels of the brain are being affected. Because if it's in the frontal lobe, it'll affect motor skills. For example, you'll see a droop on one side of the face. Or if it's affecting the temporal lobe, that would be more memory issues. In this area of the brain, it's more sensory and experience. And back here, it impacts vision. So it all depends on what area of the brain those blockages are affecting, will show a person with vascular dementia will exhibit differently. Okay. I just want to make sure I got everything in the chat and there wasn't anything I had to be aware of. Vascular dementia has three types of blood vessel blockages that can happen. One is a hemorrhage. A hemorrhage is where there's what's called a brain bleed. So the wall of a blood vessel gets so weak and then bursts open and blood is let out. And that causes pressure on the specific area of the brain where there's a bleed, which causes brain damage. So a hemorrhage is one type of a blockage that can lead to vascular dementia. A second one is called thrombosis. Thrombosis is a clot where red blood cells start to gather together, collect together as they travel through the blood vessel, and then they would get stuck at a certain point in the blood vessel. If there's a little bit of space around that clot, that oxygen and red blood cells can get around the clot, but not enough, the vessel will begin to die. And that's what I was referring to earlier. So thrombosis is where there's a clot in the vessel. And the other blockage is called an emboli. An emboli is a complete blockage of a vessel. There's no way for any red blood cells to get around it. So with the first two types the hemorrhage, and the blockage. Third type is called atherosclerosis, where the blood vessel, it has a buildup of cholesterol. Those like fatty acids that build up in the blood vessel. So as they build up along the walls of the blood vessel, blood has a more difficult time getting through that area of the blood vessel. And over time, and we're meaning like years and years, but over time, the vessels will begin to decay. So these cause vascular dementia, which is called, and the way that they exhibit it is called stepwise. They'll look fine to a certain time, and then there'll be a rapid decline. They'll stabilize until another period of decline, and it's that back and forth between stable times and decline. So that was the second most common type of dementia. The third most common type of dementia is called Lewy body dementia. Are you familiar with Robin Williams, comedian, quite famous actor? Mrs. Doubtfire was one of his movies. And of course, he was an actor in so many different types of movies. Robin Williams he was diagnosed with Lewy body dementia. Lewy body dementia comes on when it's on a younger age than Alzheimer's or vascular dementia, maybe between the ages of 50 and 70. So that's the most common age range when it will have its onset. And Lewy body dementia, you'll see most of those patients will hallucinate, see things that aren't actually there. One common hallucination is that they'll see a little boy in the distance, right? That's a very common hallucination. And it's quite startling and scary for those individuals. And often those persons with Lewy body dementia will experience REM sleep behavior disorder. REM sleep behavior disorder, well, REM sleep is when your eyes move while you're sleeping, but your body is almost in paralysis. It can't move. That REM stands for rapid eye movement. So behavior disorder for REM is where their body will move during that period of sleep when it shouldn't be moving. And sometimes it can get quite serious, like some person will punch the wall. I've had quite a few patients who have broken bones, or kicking a person who's lying beside them in bed, falling off the edge of the bed. It's quite dramatic. REM sleep behavior disorder, where they're moving during the REM period of sleep, is often a predictor of Lewy body dementia or Parkinson's disease. And it's interesting, just checking the chat. Interesting, because REM sleep behavior disorder, let me back up real fast. Lewy body dementia is where neurons in the brain, where if you look at the structure of a neuron, there's dendrites, There's a stem and there's a myelin sheath. So the neuroreceptor is a little bit like a computer, right? So a CPU, the central processing unit, is the thinking part. And that's what happens at this part of the neuron. And there's also gray matter is there. Now, the white part, the myelin sheath, is like the coil. So if you think of a computer, how there's a mouse and a keyboard connects to the computer and the monitor connects, they're all connected with cords. That's how they communicate with each other. So that's the wire, that's the pathway for your brain to communicate. With Lewy body dementia, what happens is we have a bad protein, which I'm going to sign like this. So there's one particular bad protein which will adhere itself on the neuron, on the gray matter. The bad protein is quite a long name. Alpha synucleinopathy. And really, as that protein attaches to the neuron, the cells inside where the protein is attached will start to deteriorate. They'll phosphorylate. So they'll start to harden. And then that protein doesn't hold its shape anymore. It starts to deteriorate and there leaves a hole. It leaves a hole where that protein was attached. And so you have all these holes all over the surface of the neuron. And it seems that those holes prevent the neurons from communicating with other areas of the brain, or maybe not transferring the entire message, right? So that's not a complete communication system that's happening. And that could be causing the hallucinations, at least research is leading itself to that conclusion. So if we go back to Robin Williams, unfortunately, after he committed suicide, they did an autopsy. And when they were looking at the brain, which there were many, many doctors part of this autopsy, it was found that he had quite advanced Lewy body dementia. So they were just shocked that he was able to continue to function as he had been functioning for such a long time. But again, a really sad situation. So let me repeat the four most common types. We have Alzheimer's, the most common type of dementia, vascular dementia, Lewy body dementia, which I just talked about. And finally, the fourth most common type of dementia is called frontal temporal dementia, which I'll sign as FTD. So frontal temporal dementia tends to happen about 10 to 15% of dementia cases. And that has the earliest onset between the ages of 50 and 60. Unfortunately, there are some times where we see a person with frontal temporal dementia as young as 30 or even 20, which is really unfortunate. A person with frontal temporal has large personality changes. They're not the same person anymore. Their facial expressions tend to evaporate. They have no facial expressions. And they have serious declines in their language ability as well. And the reason that we see that is because this part of the brain, the frontal lobe, tends to decline. And that decline is what really impacts their personality and its changes. So, a person in a car accident who might concuss their head against the steering wheel and do severe damage to their frontal lobe will have personality changes. And same idea with a person with frontal temporal dementia. So the difference between frontal temporal and Alzheimer's is that the Alzheimer's dementia affects mostly the temporal part of the brain, the amyloid, which is another bad protein that binds itself to the neuron. And that causes the entire neuron to shrivel. So if you do an autopsy with a person with Alzheimer's, you'll see that their brain really has shrunk because the gray matter where these protons adhere or where these proteins adhere shrivels, so it shrinks. So Alzheimer's, you'll see that decline, that shrinking here, whereas frontal temporal, you'll see that change in shape in the front. So those are the four most common types of dementia. But again, there are over 100 different kinds. So we just have barely scratched the surface of the different types of dementia. I did want to talk about risk factors related to developing dementia, but in the chat, it says, you know what, we're getting close to our question and answer time. So I think we're just going to go ahead and do that. I'll go ahead and see what questions have come up.
So if Jamie's ready for the question, I will just start asking the questions that are on the Q&A box. So I'm just gonna go in order here. So the first question is asking, is APOE E4 helpful?
Okay, that is a great question. So they're asking about APOE E4. So that stands for a polymoprotein, which is a term that relates to the chromosome 19. And that's related to a genetic form of Alzheimer's. So if a person has too much APOE4, that will interfere with the removal of the beta amyloids, right? The ones that attach themselves to the neurons. So what happens is that there's a buildup. So normally we have phagocytes, and that's a cell that will come and remove that bad protein, the beta amyloid protein, right? It will digest it essentially and remove it. But someone with APOE4 blocks that removal from happening. So then the beta amyloids build up on that neuron and end up killing that neuron. It's just not a good thing.
So the next question that I see is asking if vitamin B12 is helpful.
It's a great question right there. So B12 is found in the diet. So a person who eats red meat, but you can also find B12 in eggs, milk. So often, my mom, for example, who's a vegetarian, doesn't get enough B12 in her diet. So she has to get a B12 shot every few months. So that can be one of the things that can look like dementia, but it's not, which is a vitamin B12 deficiency or issue. There are lots of other things that can look like dementia. For example, thyroid issues. A person with that can sometimes, whether it's hypo or hyperthyroidism. So if a person's having delirium or dementia symptoms, even depression, it's important to get labs drawn so a physician can look at the levels and use that to potentially identify a low level of B12. So there's a vitamin panel that can be drawn because sometimes that person could have maybe low B12, which means that they have low production of red blood cells. And a lower red blood cell count will lead to fatigue, right? And that lack of energy, including amongst other things, can be remedied by increasing the level of B12 in their system. So that is an important thing to fix. So that's B12, but there's also vitamin B1. So a person who's an alcoholic and drinks too much has a reduced level of thiamine. And thiamine deficiency also can present itself like dementia. So really the point being, go to your PCP, get labs drawn so they can check into making sure that all of your labs are normal and then move ahead with the next part, which would typically be a neuropsychological evaluation where they can use that to kind of help begin to determine whether you have dementia or depression and begin to offer treatment recommendation.
So I'm just gonna add to what Jamie said. I'm a primary care provider, so I would be like the first line of defense. So if you yourself or one of your loved ones is feeling confused or you're having memory issues or you're just very tired, you should call your primary care provider like me and just tell them how you're feeling. And like Jamie said, we'll probably do blood work and look at different things in your blood work, like the B12. We can look at vitamin D. We can look at your thyroid. There's a lot of different things that we can look at to kind of rule out different conditions. So that's why it's important to go to primary. Once your primary has a better understanding of what might be going on with your body and your mind, then we can refer you to the appropriate specialist. So someone like Jamie. So I'm gonna move on to the next question because I can see a lot of questions here, and I want to make sure everybody gets their chance here. So the next question is asking, in the current research today, how far is the treatment for dementia gone? Like, are they coming close to a cure, or are we still working on that? And what do you think?
So, unfortunately, we don't have a cure for dementia. But fortunately, we do have some medications that will delay the onset or improve memory for a few months. How much time it'll give you, though, is maybe 6 to 9 months. And the reason being is there's a class of medications that we have called cholinesterase inhibitors. And that will help with acetylcholine. So that is responsible for memory, right? It helps with memory process in the brains, among other things. So that cholinesterase inhibitor will block the reception into the cell, which then increases more ACH in the brain. So what happens is when the brain stops making this, that stops the production of ACH, that medication can't block anything anymore because it's not present. So we haven't been able to invent, right, or make that on our own yet. So hopefully, as research goes along, maybe we can do something along that line. There's one medication that we tend to use, well, there's several different types of that ACH. The first one is donepezil. There's glantamine, and there's another ristavagine. There's a few others, but those are the top three that we prescribe. There are some side effects related to the ACH class, but we have to consider pros and cons. Unfortunately, there's no cure yet. But the ACH medications do other things as well. And there's another medication that seems to show promise, which is beta with the related to the beta amyloid blocker, right, where they want to remove that protein off the neuron. So that's another avenue that research is taking, but there are again side effects with those medications as well, including higher risk for brain bleeds. So with each medication, there are pros and cons. Most of the things that we have to help dementia really are more behavioral supports.
So the next question I found to be very interesting. So we were talking about FTP. So the fourth one that he was talking about, they are asking if FTP is often misdiagnosed as schizophrenia or other psychiatric disorders. You understand?
I'm sorry, I couldn't see the interpreter.
You want me to say it again?
Can you say that again, Sarah, please? Thank you.
So I'm gonna read it, okay? Okay. Is FTP often misdiagnosed as schizophrenia or other psychiatric disorder?
Ah, okay. Thank you for clarifying. Thank you. So, frontal temporal dementia, FTD, has personality changes, whereas LBD, Lewy body dementia, has more hallucinations. So I'm guessing maybe that person's asking me, are they wondering if LBD looks like schizophrenia or is misdiagnosed as schizophrenia? It's an interesting question right there. So schizophrenia tends to be diagnosed early in a person's 20s. So much younger age. It's rare for a schizophrenic person to develop at an older age. So as time goes on, right, LBD, Lewy body dementia, which comes on between 50 and 70 years old, helps us to recognize what's going on. And there's a whole collection of symptoms, like I mentioned with the REM sleep disorder, right, where their body will actually move. How they walk also will sometimes have something called magnetic gait. So as they walk, they don't pick up their feet. They tend to keep their feet very close to the ground. So these are all symptoms that we use to diagnose Lewy body dementia. But that was a great question.
So we have about 4 minutes left. I'm gonna try to do 2 more questions before we wrap up.
Okay, yeah.
Okay, so the first one, is there any way that you can try to avoid getting dementia?
So, yes, there are a lot of things we can do to reduce our risk for dementia. And interestingly, our deaf and hard of hearing population, and also populations who are late deafened, have an increased risk for dementia. So it's really, really important for us to try to make sure that we reduce our risk. And we can do, well, several things. But one of the most important things that we can do is exercise. The reason why exercise is so helpful is because when you exercise, you get circulation, and that oxygen throughout your entire system. And oxygen is always a good thing. So when we have that oxygen diffuse throughout our body, it lowers our blood pressure. And increased blood pressure is not good. That tends to lead to vascular dementia, right? I don't remember me talking about that one, where the blood vessel problems. So when we keep a good, healthy blood pressure, it's helpful. And one of the things we can do best things for that is to exercise. So that's one of the best ways to reduce your risk.
So I'm gonna wrap up with a really good last question. Um, are there any challenges in diagnosing dementia in the deaf and hard of hearing population?
Yeah. many neuropsychologists will use, well, their hearing, and they use a testing instrument that's made for the hearing population. And so sometimes there can be a misunderstandings or misdiagnoses of an individual. So it's really important that you have someone that's aware of the cultural, linguistic, right, which communication, how we use ASL in a direct evaluation, and then to take that data and interpret it appropriately to lead to an appropriate diagnosis. So yes, it has and is a big challenge.
So I am gonna wrap up. I know there were a lot of amazing questions, and I am really sad that we have to go tonight because Dr. Wilson is an amazing speaker. I just want to ask Dr. Wilson right here,
Oh, thank you.
are you comfortable with the audience members reaching out to you about their questions if they have more questions, or what would you like to do about that?
Of
Okay.
course, yes. Feel free to contact me. I would appreciate that. Yeah.
Okay. So thank you so much again, Dr. Wilson, for joining us tonight. I also have to thank the University of Michigan,
Oh, yeah. Thank you
and
for inviting me.
Disability Health Department, family medicine, and then we have James and Lindsay from the interpreting team at University of Michigan. We have Kate, who is our captioner tonight, and then we have people behind the scenes such as Sanjana that made this a wonderful talk tonight. We will be having another dump health talk, I think next month or in March, and the topic will be announced, and you will get the information on social media. So stay tuned for that. If you want to participate in our dump health talk, or you have ideas for topics, or you have ideas for speakers, feel free to reach out to us. We're always looking for new and better things to talk about. So thank you again, Dr. Wilson. And say good night to everybody. Stay safe and healthy, okay?
Thank you. Yes. Stay safe, everyone. Thank you.